Multiple sclerosis. Multiple sclerosis is a chronic autoimmune disorder characterized by demyelination of the central nervous system, or CNS. The autoimmune response in multiple sclerosis targets oligodendrocytes, the myelin-producing cells of the CNS. This response is thought to be caused by molecular mimicry. Exposure to a foreign antigen with structural similarity to myelin proteins leads to formation of autoreactive T cells. Primed T helper cells then enter the CNS where they are exposed to myelin antigens, triggering the release of cytokines such as interferon gamma, interleukin 17, and TNF-alpha. These mediators drive a localized inflammatory response that leads to recruitment of additional leukocytes, including macrophages and cytotoxic T cells that cause damage to oligodendrocytes. B cells also become activated within the CNS and secrete myelin-specific immunoglobulins that activate complement, further contributing to myelin breakdown. This process leads to the formation of focal demyelinated plaques within the central nervous system. Acute lesions are characterized by significant perivenular inflammation that results in a leaky blood-brain barrier. Infiltrating macrophages containing myelin debris can also be seen throughout the lesion. Although the inflammatory response initially causes oligodendrocyte depletion with relative sparing of axons, significant axonal damage can occur over time. Chronic plaques are characterized by extensive demyelination with reduced inflammation, focal axonal loss, and hyperplasia of astrocytes forming a glial scar. Although axonal loss can eventually contribute significantly to neurologic dysfunction, the symptoms of multiple sclerosis initially develop as a result of acute demyelination. In normal myelinated neurons, the depolarization impulse is regenerated at discrete points along the axon called nodes of Ranvier, where sodium channels are concentrated. The myelin sheath serves as an insulator that allows the impulse to propagate between two adjacent nodes. Disruption of the myelin sheath causes the depolarization impulse to rapidly degrade, preventing it from reaching the next node. The resulting conduction block manifests clinically as one or more neurologic deficits. Over time, surviving oligodendrocytes can partially remyelinate neurons, and sodium channels can redistribute more evenly, allowing for some restoration of signal transmission that can result in periods of symptom remission. Multiple sclerosis most commonly presents in individuals aged 15 to 45, and females are 3 times more likely to develop the condition than males. A key factor for disease development seems to be infection with Epstein-Barr virus, which encodes an antigen that is structurally similar to a glial cell adhesion molecule. Exposure to the virus in susceptible patients is thought to trigger sensitization of the autoreactive T cells responsible for multiple sclerosis. Another contributing factor is vitamin D deficiency, which increases the risk of multiple sclerosis due to the immunomodulatory effects of vitamin D. Geographic locations farther from the equator are also associated with increased disease incidence, which may be related to increased viral exposure in colder climates, as well as reduced sunlight and decreased vitamin D synthesis at higher latitudes. Genetic factors conferring increased risk have also been identified, including certain MHC alleles such as HLA-DRB1. Multiple sclerosis is a clinically heterogeneous condition. Specific neurologic manifestations and overall disease progression can vary substantially from person to person. Most patients experience a relapsing, remitting course characterized by clearly defined attacks of neurologic symptoms with intervening periods of partial or complete recovery. The symptoms typically develop over 1 or more days and then gradually improve over the following weeks. Periods of remission typically last months. Less commonly, patients experience a more progressive course with relentlessly worsening neurologic disability. Primary progressive multiple sclerosis is characterized by a gradual progression of neurological disability from disease onset without distinct relapses or remission, while secondary progressive disease follows an initial relapsing remitting course but later progresses to a more steady increase in neurologic disability. Although the demyelinating lesions of multiple sclerosis can affect many different areas of the CNS and cause a wide variety of symptoms, there are particular neurologic findings that are highly characteristic of the disease. Common ocular manifestations include unilateral optic neuritis and internuclear ophthalmoplegia. Optic neuritis presents with painful monocular vision loss, an afferent pupillary defect, and optic disc swelling. Internuclear ophthalmoplegia occurs due to involvement of the medial longitudinal fasciculus and is characterized by an inability of the ipsilateral eye to adduct when the contralateral eye abducts during horizontal gaze. Sensory abnormalities affecting the limbs and face are also common, occurring in almost all patients at some point during the disease. Motor findings occur somewhat less frequently and include upper motor neuron weakness and spasticity due to involvement of the descending motor tracts. Gait disturbance and balance problems can also occur due to disruption of cerebellar pathways. Transverse myelitis is another common presentation that is associated with sensory and/or motor abnormalities below the involved spinal cord level. Two characteristic features of multiple sclerosis are Lermite sign and Uthoff phenomenon. Lermite sign describes a shock-like sensation radiating down the spine or limbs that occurs when the neck is flexed. It is caused by stretching of hyperexcitable demyelinated axons within the dorsal column of the spinal cord. Uthoff phenomenon refers to worsening of the symptoms of multiple sclerosis during heat exposure, such as with hot climates or warm baths. This occurs because increased body temperature impairs neuronal impulse conduction, particularly through demyelinated nerves. The diagnosis of multiple sclerosis is predominantly clinical and based on identifying a pattern of neurologic injury disseminated in space and time. In some patients, identification of the necessary CNS lesions can be based entirely on history and physical examination findings. For example, a patient currently presenting with numbness and paresthesia in the leg who also has a history of optic neuritis occurring 1 year ago would meet criteria for lesion dissemination in both space and time. Patients being evaluated for multiple sclerosis also undergo imaging of the central nervous system to confirm the presence of demyelinating plaques. MRI of the brain and spine with contrast is the imaging study of choice, as it can not only determine lesion locations, but also help determine age. Demyelinating plaques are typically hyperintense on T2-weighted imaging and are often found in the juxtacortical, paraventricular, infratentorial, and spinal cord regions. Newer, more active lesions are contrast-enhancing due to the leaky blood-brain barrier, while older lesions without significant inflammation are non-enhancing. Therefore, MRI can provide additional evidence for meeting the space and time criteria for diagnosing multiple sclerosis. Cerebrospinal fluid analysis is an ancillary test that may be performed in certain patients to look for the presence of oligoclonal immunoglobulin bands. These bands are formed by the various anti-myelin antibodies produced within the CNS by infiltrating B cells. While the presence of CSF immunoglobulin bands is not specific for multiple sclerosis, It is a highly sensitive finding that can be beneficial in cases of diagnostic uncertainty. The management of multiple sclerosis focuses on treatment of acute attacks and modifying disease progression. For treatment of acute relapses, high-dose glucocorticoids are usually administered to reduce CNS inflammation and decrease the length of the attacks. However, acute treatment does not reduce the risk of subsequent relapses or improve long-term disability. As such, most patients are also started on disease-modifying therapies as soon as possible to reduce the frequency and severity of relapses and slow overall disease progression. There are several options for disease-modifying drugs, each with varying efficacies and side effects, but they all act as immunomodulatory medications that reduce inflammation within the CNS. Example agents include interferon beta, which acts via multiple mechanisms to reduce the Th1-Th17 immune response, glutarimer acetate, which activates myelin-specific regulatory T cells to suppress the immune response, fingolimod, a sphingosine-1 phosphate receptor modulator that prevents lymphocytes from exiting lymph nodes, ocrelizumab, an anti-CD20 monoclonal antibody that depletes B cells, and natalizumab, a monoclonal antibody that binds to alpha-4 integrin receptors on endothelial cells, preventing leukocyte extravasation into tissues. To sum up, here are the key points to remember. Multiple sclerosis is a chronic autoimmune disorder of the CNS characterized by demyelination and neurodegeneration. The disease is likely triggered by exposure to foreign antigens with structural similarity to myelin proteins, leading to formation of autoreactive T cells that destroy myelin-producing oligodendrocytes, with relative sparing of axons. It most commonly presents in females age 15 to 45. Epstein-Barr virus infection is a key risk factor. Other factors include geographic locations farther from the equator, reduced sun exposure, and vitamin D deficiency. Multiple sclerosis can present with a wide range of clinical symptoms, including optic neuritis, internuclear ophthalmoplegia, sensory abnormalities, muscle weakness, cerebellar dysfunction, and transverse myelitis. Other characteristic features are Lhermitte sign, a shock-like sensation when the neck is flexed, and Uthoff phenomenon, which refers to worsening of symptoms with heat exposure. The clinical course can be highly variable, but most patients experience a relapsing remitting pattern with clearly defined attacks and intervening periods of partial or complete recovery. The diagnosis is made by identifying a pattern of neurologic injury disseminated in both space and time, which can in some patients be apparent based on clinical history alone. An MRI of the brain and spine with contrast is also performed in all patients and can aid in the diagnosis. Testing the cerebrospinal fluid for oligoclonal bands can also be a useful adjunct. Acute attacks are treated with high-dose glucocorticoids, and most patients are started on disease-modifying therapies to reduce the frequency and severity of relapses.